Started.
So in this lecture, we'll study about fluid therapy. This fluid therapy lecture is divided into two parts. One is crystalloid fluid therapy and second is your colloid therapy. In crystalloid therapy, we'll study some isotonic or replacement fluid and hypotonic or maintenance fluid and hypertonic. And at the end, fluid overload. So this is the first part of lecture, crystalloid therapy. In second video, we'll cover colloid therapy. Colloids may be two types, natural and your synthetic. Natural ones are whole blood, packed RBC, fresh plasma, fresh frozen plasma, and HbOC. So this part we'll cover in next lecture. So first we'll see the fluid therapy, mainly crystalloid therapy. So before going to therapy, first we'll see what are fluid. First we see the fluid. If we look, there is one term, total body water. This is the animal which is having two components. One is total body water, that is 60% of the body weight. What is the remaining? What is the remaining 40%? That remaining 40% part is the dry matter. So we are focusing on the fluid. Fluid means the part which is a component of total body water. In this body weight, 60% is your total body water. Remaining 40 is the dry matter. So first we'll see this 60%, that is your total body water. In case of animal nutrition, in module also I have given one analogy with the animal nutrition where dry matter is divided into roughages and concentrate. Roughages are 2/3 and concentrate is 1/3. And if we look at these roughages, they are dry and green roughages. That is 3/4 dry roughages and 1/4 is green roughages. This is how we divide the dry matter in case of animal nutrition. Similarly, in case of fluid therapy, this total body water is divided into 2/3 and 1/3. This 2/3 part is your intracellular fluid and 1/3 part is your extracellular fluid. If we divide this 1/3 extracellular fluid, again it is divided into 3/4 and 1/4. This 3/4 is nothing but your interstitial fluid, and the 1/4 is your intravascular fluid, also called as plasma. If loss of this interstitial fluid occurs, then we use the term dehydration. Dehydration. If losses occur from this compartment, we call dehydration. If losses occur from this compartment, the term used is hypovolemia. Hypovolemia. So the total body water is divided into two parts, 2/3 your ICF, 1/3 your ECF, and that is 3/4 ISF and 1/4 is your plasma. The loss of this compartment, fluid if there is loss of fluid from ISF compartment, the term uses dehydration, and from this compartment we use the term hypovolemia. Then in this ECF compartment, there is one more terminology which is called as third space. Third space means pleural fluid. Third space means peritoneal fluid. Third space means CSF. Third space means aqueous humor. And there are many. So if fluid accumulate in the third space, for example, in the peritoneal cavity, we use the term ascites. But that is also a kind of compartment, and that is a part of ECF. So these are the fluid compartments and the distribution of fluid in these compartments. After fluid compartment, if we look at the fluid itself, that is your crystalloid and your colloid. A small difference between these two is crystalloid, they can easily cross the blood vessels, they can enter interstitial fluid. But colloids are large molecular weight substance. They cannot cross the capillary membrane. So they remain inside the compartment. But crystalloid, they can come outside of the plasma and they enter ISF, or they may enter into the cell. These are small molecular weight substances. In these crystalloid cases, no immune response is generated. In case of colloid, the problem is immune responses. There may be some allergic responses. Suppose you are using albumin of human origin. Suppose you are using HES. We'll discuss in next lecture. So they remain distributed from vascular compartment to interstitial, then from interstitial to water, but they remain inside the compartment and they pull the water inside this compartment because, and they pull the water because of osmotic pressure. That is called colloidal osmotic pressure. So this is a simple difference between these compartments. So second is movement of fluid. Movement of fluid. This is the plasma. This is the plasma. These crystalloid, they are permeable to capillary. Means from the plasma, they can easily enter ISF. And this entry point is a simple passive diffusion. This is passive. But here, these are cells. Cells are made up of cell membrane, that is lipid bilayer. So these crystalloid, from the interstitial fluid, if they enter here, that process of entry is active. That process entry is active. So the movement of fluid from plasma to ESF, ESF to plasma is simple passive diffusion. But from ESF to here is the active transport, because they have to cross the cell membranes. If we look at the crystalloid contain water plus electrolyte plus non-electrolyte. These crystalloid may be divided into two parts. One is replacement. One is replacement crystalloid and one is maintenance. One is maintenance crystalloid. Replacement crystalloid, they contain sodium similar to extracellular fluid. That is, or you can say similar to plasma. Replacement fluid. That is equal to 140 millimole per liter. Because the sodium is similar to ESF, similar to plasma, these are also called isotonic. They are called isotonic. These maintenance fluid, they have sodium less than ESF. So they are also known as hypotonic. They are also called as hypotonic fluid. Hypotonic fluid. So replacement crystalloid have sodium similar to ECF or plasma. They are known as isotonic fluid, and maintenance fluid have sodium less than the plasma or extracellular fluid. They are hypotonic fluid. In case of replacement crystalloid, this is the vascular compartment. If we administer this replacement if we infuse through IV route, then here in the intravascular compartment, one third remain inside this compartment and 2/3 will come out. 2/3 will come out. Where it will come out? In the interstitial fluid. In the interstitial fluid. So replacement crystalloid, if you infuse them through the IV route, only 1/3 part will remain in the plasma or your intravascular compartment. 2/3 part will come out into interstitial fluid within 1 hour. It means whatever fluid you have infused, 1/3 will remain here, 2/3 will come out. So we need large volume of crystalloid, replacement crystalloid, to maintain their volume inside the intravascular compartment. Because 2/3 part is going out, only 1/3 is remaining. So large volume is needed to saturate this compartment. Or to, if there is hypovolemia, the blood volume is less, then you have to give large volume of crystalloid replacement fluid. Why large volume? Because 2/3 will come out and 1/3 is there. What happens in case of maintenance fluid? Similarly, if you give maintenance fluid as IV, more than 90% will leave the compartment and will enter into ISF, interstitial fluid. Less than 10% will remain here. So in case of hypovolemia, when the volume is less in the intravascular compartment, maintenance fluid, maintenance crystalloid are of no use, because after administration, more than 90% will leave this compartment and it will enter primarily into interstitial fluid. So we use crystalloid fluid to increase the volume, but in large volumes. Why large volumes? Because only one third will remain there, two third will come out. So these are replacement colloid, these are crystalloid, and these are maintenance crystalloid. They have same sodium as ECF, so they are isotonic, and they have less sodium, so they are hypotonic. The third type of crystalloid are hypertonic. Third type is the hypertonic. That is 7.5% NaCl. Hypertonic means if we give hypertonic infuse here, they will pull the water out of the cells. They will pull the water out of the cells. So when these hypertonics are needed, when there is immediate need to increase intravascular volume, and when that need is there during surgery. During surgery. Suppose during surgery there is loss of volume. You are removing a tumor, the tumor itself having its own blood supply, that may lead to the loss of blood. So for the immediate replacement, for the immediate increment of the volume, we give hypertonic saline. So these crystalloid, if we summarize the crystalloid, they are mainly three types. One is replacement, that are also called as isotonic crystalloid. Second is your maintenance type, that are hypotonic, and third is your hypertonic. What are the example of tonic? Your 0.9% NaCl, NS, RL, plasma light, or your normosol. These are three examples. For hypotonic, D5 and 0.5%, 0.45 normal saline. And what is hypertonic? Your 7.5% normal saline. So these are the three types of crystalloid fluid. One is your replacement, that is having same sodium as the ECF, that is isotonic. Second is maintenance, that is hypotonic. And the third one is your hypertonic. Next topic, before starting the fluid therapy, first we'll see the difference between the plasma and normal saline or your RL, lactated ringer solution. These are the two commonly used crystalloid. So first we see plasma. The normal pH of plasma is 7.4. Okay. In case of plasma, NS, this is 142, and Cl in plasma is 104. Potassium is 4 and calcium is 1.25 or bicarbonate. This is our extracellular buffer in case of plasma, which is present as 24 milliequivalent per liter. And the osmolarity of our plasma is 280 to 310. So first we'll compare This is the plasma and this is the normal saline which is available in the market. The pH of this normal saline is 5.5. It means this is acidic. If we look at the content in the name itself, normal saline Na plus or Cl minus. That is 154, 154. And if we add the osmolarity equal to 308. If we look at sodium inside our body is 142 and this is 154. The difference is negligible. The difference is 154 and 142 is negligible. But if we look at the chloride, this difference is of 50 and this is not negligible, this is significant. This is significant. What does it mean? The electrolyte which are present in my plasma and the electrolyte which is present in the normal saline, they are not balanced. So normal saline is an example of unbalanced electrolyte solution. But if we look at the sodium of the plasma and our product NS, this is nearly similar. Not identical, it is similar. When sodium is similar, we use the term isotonic. Isotonic. So NS is an example of isotonic unbalanced electrolyte. The next thing is sodium is okay, chloride 50 extra. If we look at this 50, this NS is having extra chloride. This is additional 50. It means whenever you infuse normal saline into the body, this removal of the chlorine is a function of your kidney. Chlorine is removed in the urine by the kidney. So whatever extra you are putting, that will be a load on glomerulus. And kidney has to work extra to remove this 50 chloride that is coming from the NS. And this extra will load the glomerulus and it will come out through the urine. So in case of renal insufficiency, renal failure, the NS will give extra load on the glomerulus because the main path of removal of chlorine is the urine. So in which conditions this NS is used? This normal saline which is having extra chlorine, that is 50 is extra. So the indication is in case of vomition, this is our GIT. Vomiting means upper part of GIT losing the gastric fluid. Gastric fluid contain HCl, means Cl. So if there is severe hypochloremia, if you are losing more chlorine, then the benefit of NS, that is having extra 50 chlorine, we can utilize. So in case of vomiting, if you give NS, then it is having extra chloride, that will be compensated. So the main indication for the normal saline is the case where chlorine is reduced inside the body, when there is less chlorine, because NS is having extra 50 chlorine. Another thing where NS can be used in case if a patient is having hypercalcemia, hyperkalemia, more potassium. So we can use NS because it contains only NaCl. So in case of patient having more calcium inside body, more potassium, we can use NS. Where we do not use NS in case of hypertension, high BP, hypertension. We should not use this NS because already the sodium is high. So in case of hypertension, we should not use normal saline. So the next is your RL, LR or RL. If we look at the pH of RL, this is 6.5. Okay. The sodium here is 130. Chlorine here is 109. And potassium is 4. And there is lactate. There is lactate 28 milliequivalent. So there is lactate is there. This lactate occur as a buffer to maintain the pH of the solution 6.5. Lactate act as a buffer. So in case of RL, lactate is a buffer. But our human body, animal body having buffer called bicarbonate. So during the manufacture of this bottle, why they have added lactate? Why not bicarbonate? These fluids are already sterilized fluid. These are sterilized fluid. So when they go for the sterilization of this fluid, then this bicarbonate will be break down into CO2 and H2. So this bicarbonate is unstable. That's why they are using lactate, which is a stable buffer. So this is the one thing about the RL, that it is having lactate, not bicarbonate, because body has bicarbonate and this is having lactate. So lactate is stable buffer to maintain the pH 6.5. So that's why lactate is added. The second important difference between your RL and your plasma. Sodium and chlorine. See, body having 104 and your RL having 109. So that difference of NaCl is negligible. It means the electrolytes are balanced. So RL is called balanced electrolyte solution. And because it is having sodium similar to ECF or plasma, so it is also called isotonic. So the full name of RL will be isotonic balanced electrolyte solution. And second thing about RL is this lactate. In ICAR 2018, there was one MCQ related with this lactate. This lactate in the RL, it will enter into your liver. Enter into your liver. And liver convert it into bicarbonate. This is the metabolism of the lactate inside our body. So the MCQ was that which of the fluid is contraindicated in liver failure, hepatic insufficiency. If liver is not working, then lactate will not be converted into bicarbonate. So proper functioning of liver is important for RL. So in liver failure or hepatic insufficiency cases, like this RL is contraindicated. So this RL having lactate and the liver is converting into bicarbonate, so we can use this for in the cases of metabolic alkalosis, not alkalosis, acidosis. Acidosis. Why we can use in metabolic acidosis cases? Because the lactate inside the liver lactate by the liver converted into bicarbonate. If there is acidosis, this bicarbonate will neutralize the acidosis. So RL is a fluid of choice in case of metabolic acidosis. So in case of diarrhea, there is loss of bicarbonate. So the fluid of choice will be RN. In case of vomiting, only vomition. What is the loss? Loss of HCl from the gastric fluid. Although may be some sodium loss is also there because gastric fluid also contains sodium. So loss of chloride and the sodium, the fluid of choice will be your NS. So these are the two commonly used fluid which are having, both are isotonic, but one is balanced and one is unbalanced. Now come to fluid loss, which is also known as fluid deficit. We are having three compartments. One is your intravenous compartment. If there is loss of fluid from this compartment, we use the term hypovolemia. Then this is the ISF, interstitial compartment. If there is loss of fluid from this compartment, the term we use is dehydration. And third is the intracellular, inside the cell. If water comes out from the cell, then this is intracellular dehydration. But to measure this, we do not have any physical examination method. See, for hypovolemia, we can measure blood pressure, heart rate, CRT. For dehydration, we can check mucous membrane, skin tint, skin turgor, and sunken eyes. Sunken eyes. But for intracellular, there is only some laboratory test, laboratory diagnosis are there, like increased sodium or some ions. So fluid loss may be any of the one compartment. If it is from the IV compartment, your capillary blood vessels compartment, hypovolemia. ISF, dehydration. So these two terms, one is hypovolemia, is not equal to dehydration. Both are different. Hypovolemia means loss of fluid, intravascular compartment fluid loss, and it is nothing but your circulatory shock. Circulatory shocks may be three types, like cardiogenic, distributive, and your hypovolemia. Out of those three, four, the most common is the hypovolemia. So hypovolemia, IV compartment volume is going down. Because of this, if volume is less, so less blood flow will go to tissues. As we know, blood is a source of oxygen, glucose. So if less blood go to the tissues, it means there will be hypoxia, less oxygen. And because of hypoxia, what will happen? Anaerobic glycolysis. Anaerobic glycolysis. Two things will happen. One is lactic acid and one is less ATP. Because of less ATP, cell membrane function will be disturbed. Because of lactic acid, metabolic acidosis will be there. metabolic acidosis will be there. And because of this metabolic acidosis, there may be tachypnea, respiratory rate increases. So hypovolemia is the loss from the intravascular compartment. So that if this compartment volume is less, so less blood flow will be reached to the tissues. Less blood flow means what? Less oxygen, less glucose. That may lead to, at cellular level, anaerobic glycolysis, and that may lead to less ATP. And because of ATP, the cell membrane pump, which are ATP dependent, sodium, potassium, ATPase, they will not function. The function of cell membrane will be disturbed. One product is also formed like acid. This acid may lead to acidosis, and because of acidosis, respiratory rate increases tachypnea. So this is related with hypovolemia. But what is dehydration? Dehydration means loss from the interstitial fluid compartment. Interstitial fluid compartment. That is called dehydration. That is called dehydration. We have some physical examination to assess the dehydration. Like as I told, skin turgor and mucous membrane and your sunken eyes, duffy abdomen, and some, if you go for lab diagnosis, remember the two, increase in the PCV and elevated your total protein. For hypovolemia, we can diagnose by heart rate, BP, CRT, central venous pressure, and your okay, listen. So these are hypovolemia versus dehydration. Then now we'll start with the fluid therapy. Component of this fluid therapy. There are three components. Of fluid therapy. One is resuscitation, one is replacement, and one is maintenance. So these are the three components of the fluid therapy. First we'll see the first component, that is, what is the meaning of the term resuscitation. Those patients which are hypovolemic, which are having shock like circulatory shock, those patients which are hypovolemic, they need resuscitation. In this case, restoration of the intravascular compartment is required. So in case of resuscitation, IV intravascular volume is restored. Because in case of hypovolemia, which volume is less? Intravascular. So in this resuscitation, it is a kind of emergency situation where we give large volume of fluid intravenously. So in case of resuscitation, in this case, we administer shock dose, and this was your ICR 2019 MCQ. That in case of shock, what is the dose rate in case of dog? So remember, in case of dog, this is the 90 ml per kg, and in case of cat, it is 60 ml per kg. So this is the shock dose, or it is also called shock bolus. In case of dog, 90 ml per kg, and cat, it is just opposite 60. The the question is how to give this bolus. If I say for dog 90, for cat it is 60, then 90 ml per kg. Do not give the whole dose, total dose at once. What you do, you give 1/4 of the total dose. 1/4. What is the 1/4 of 90 ml? That is 22.5 ml per kg, and 60 is 15 ml per kg. So first you give 1/4 of the total dose over the 15 minute. For example, there is a 10 kg dog and the dose rate will be 90 ml, means total is 900 ml per kg. So out of this 900, you first give the 1/4. 1/4 of the 900 ml over the 15 minute. After giving this 1/4 dose, after giving this 1/4 dose, you reassess the patient for endpoint of EOR. What is EOR? EOR means restoration of the vital signs. So after giving the 1/4 dose, reassess, re-evaluate your patient for whether it is the all like BP, heart rate, mucous membrane, all these vital signs are restored or not. The PCV is more than 25% or not. Check for the urine output also, whether it is more than 1 ml per kg per hour is or not. So if you check all these signs, if they becomes normal, then you stop giving your therapy, your resuscitation. So the resuscitation means in case of hypovolemia, in case of circulatory shock, we give in the form of a bolus. In case of dog 90 ml and case of cat 60. Well, initially we give 1/4 of the total dose, then we reassess the parameters like BP, heart rate, PCV, urine output, all. If they become normal, then we stop giving resuscitation dose. So if there is hypovolemia, along with there is also hypoproteinemia, means protein level is also less, then you go for the synthetic colloid like ethyl starch, hexaethyl starch, or heta starch like therapy, hydroxyethyl starch. Then we give this colloid at 5 ml per kg over the 15 minute. So only hypovolemia is there, go for the resuscitation, shock boluses, and if there is hypoproteinemia is also there, then add these colloid because they maintain the volume inside the intravascular compartment, and they maintain the or they elevate the uh, osmotic pressure. After resuscitation with your 90 ml or your 60 ml, then the second component of fluid therapy is the replacement. Is the replacement, also called as rehydration. Rehydration. See, there are three compartments: intravascular, ISF, and your intracellular fluid. This compartment, this compartment deficit is corrected. We have corrected IV compartment deficit with the help of resuscitation therapy. In case of resuscitation, we have given 1/4 of the dose and it is corrected. Now, if there is dehydration, means the fluid is also lost from the ISF compartment. So in which cases both are lost? Means hypovolemia is also there and dehydration is also there. Yes, there is one case, parvo puppies. In case of parvovirus infection, there is vomiting, diarrhea, hemorrhagic diarrhea. In that case, hypovolemia is there. In that case, this interstitial fluid volume is also lost. That is, dehydration is also there. So, if you are treating a parvo puppy, so if there is hypovolemia, so we have given a resuscitation dose and it is corrected. Then the next thing to correct is your ISF. So we will give replacement crystalloid. Replacement crystalloid. Replacement crystalloid are isotonic, your balanced electrolyte solution. We'll give this. There is dehydration. To correct that dehydration, we'll give isotonic balanced electrolyte solution. For example, your RL. For example, plasma light. How to calculate? In this case, in replacement therapy, not only the fluid loss because of dehydration, plus there may be plus or minus, there may be some ongoing losses. What are ongoing losses? Maybe vomiting or diarrhea. So in this case, we have to take care of both. One is dehydration and one is ongoing losses, that is vomiting and diarrhea. So in replacement component, rehydration component, we should take care of dehydration as well as ongoing losses. How to take care of dehydration? So the formula for this replacement equal to fluid deficit plus ongoing losses. This is calculated simply by the body weight of the dog into percent dehydration. Percent dehydration. So plus ongoing losses which may be there or which may not be there, like vomiting and diarrhea. So this is how we use the replacement crystalloid isotonic balanced electrolyte solution to correct the fluid deficit, that is your interstitial fluid is lost, we are correcting this, plus we are giving some volume for vomiting diarrhea like ongoing losses. The third component of the fluid therapy is the maintenance. Maintenance. Maintenance, when to give this maintenance? Suppose when your healthy animal, which is volume is okay, blood volume is okay, hydration is okay, but this animal is not eating and it is not drinking. Not eating, not drinking. So we'll go for the maintenance therapy, maintenance fluid. So what is the rate at which you will administer your fluid? So this is 40 to 50 ml per kg per day, means for 24 hours. 40 to 50 ml. So for maintenance therapy, as I told you, for maintenance therapy, the maintenance crystalloid are those which are hypotonic. Example D5, example 0.45% your NS, 50%. So in maintenance therapy, no need to give replacement crystalloid like your RL and other fluid. So we give hypotonic, 50% strength fluid. So the fluid therapy component, if we see, there were three components: resuscitation, replacement, and the maintenance. In resuscitation, there were two shock boluses, 90 ml, 60 ml, and we gave 1/4 and check for the restoration of your normal parameter, BP, heart rate, all these. In case of replacement, what we are doing, dehydration is there, ISF loss, we are correcting this with the help of isotonic crystalloid. In case of maintenance, the normal cellular metabolism requirement are given, that is 40 to 50 ml per kg per day. This value may be increased in case of pediatric animal. So these are the three. So if I make in form of diagram, this is your intravenous, intravascular compartment. To correct this, we use resuscitation. If there is only this loss, interstitial, that is dehydration, we will use replacement crystalloid. If both are there, in case of parvo, puppies, then both therapies should be given. First will correct the circulatory shock, that is emergency condition, then will correct the dehydration. Then there is one more concept, intraoperative, means during surgery, the fluid therapy. So there are two. One is for elective OHE or castration. This was the MCQ in your NET exam 2019. What is the dose rate during surgery if there is elective healthy animal? That may be your 5 ml per kg per hour. Other than this, normally for any other cases, the fluid therapy rate will be 10 to 15 ml per kg per hour. Suppose there is one surgery of 1 hour, You are doing a pyometra surgery, which is taking 1 hour, and the dog is 10 kg, then at your fluid will be 100 ml required. So this is the fluid requirement during surgery. Hello,
हाँ
clear है?
क्लियर
Okay. Then in fluid therapy, there is one more small concept that is called adjunctive therapy. Adjunctive therapy means there is in this animal there is ascites. In there is existing extra fluid, extra fluid. That is the ascites. Existing fluid. So adjunctive therapy means to replace this extra fluid with the fluid therapy. With the fluid. Which fluid? Suppose we are using mannitol. We are using 20 or 25% mannitol. So there is one fluid which is in our hand inside the bottle, that is the mannitol. This fluid is used to remove or replace this fluid. If we give mannitol IV, this fluid will go out inside the urine. So this is the meaning of adjunctive therapy, where one fluid bottle is given, this ascites fluid will be removed. This is adjunctive therapy. At the end, routes of fluid therapy. The most commonly preferred route is your IV route. Suppose the IV route is not accessible, there is no access to IV route, we'll go to intraosseous route. That may be your proximal femur and tibia crest, tibia bone or your femur bone. These are the two routes, IV or intraosseous. Subcutaneous route is not preferred for the patient of hypovolemia. The question is why this is not preferred. In case of hypovolemia, the volume is less, means there is circulatory shock. In case of hypovolemia, subcutaneous route is not used because in case of circulatory shock hypovolemia, the blood will be diverted to your heart and your brain. These are the two main organs where the blood will be diverted from the periphery to these vital organs. So if we look at the periphery, the blood is not there because there is vasoconstriction. If you give your fluid through the subcutaneous route, the vessels are already constricted, then there will not be any absorption. So, no benefit to give the fluid in case of hypovolemia by the subcutaneous route because the vessels are already constricted, vasoconstriction, no absorption because the whole blood is diverted towards the heart and brain. Like during exercise, the whole blood is diverted towards our skeletal muscles. Similarly, in case of shock, blood is diverted to the heart and the brain. The last topic of fluid therapy is the fluid overload. There are some clinical signs in case of fluid overload, and these signs are tachypnea, tachycardia. In case of cat, remember two special signs. One is chemosis, that is the conjunctiva swollen, filled with the fluid, chemosis, and second is the gallop rhythm. These two signs in cat fluid overload. Other signs like serous, that is watery nasal discharge. There may be difficulty in breathing, dyspnea, and if you heard your lung sound, there may be some crackles, abnormal lung sound, and there may be coughing, cough, and jugular vein distension. So these are the some of the signs of fluid overloading. So in this lecture, we have completed that total body water that was divided into ECF and ICF, and ECF was divided into ICF or plasma. Then we saw crystalloid. Crystalloid. There may be two types. One is replacement, which are having same sodium equal to your ECF, and one was your maintenance, that is having sodium less than ECF. Then these were isotonic and these were hypotonic. We compared these fluid bottles with the plasma versus NS, plasma versus RL. Then fluid losses from this compartment, that is hypovolemia. This ISF compartment, that was dehydration, and this is a type of circulatory shock. Treatment was resuscitation, shock dose, and dehydration treatment was replacement, that is replacement. And another was the maintenance to maintain the normal physiological cellular metabolism. And at the end, fluid overload. In next lecture, we'll see colloid, which are of two types. One is natural and one is synthetic. Synthetic and natural. These natural ones will discuss in the blood with blood transfusion, because these components are whole blood, your plasma PRP, packed RBC, oxyhemoglobin, Here, the most commonly used is hydroxyethyl starch. These are the colloids.